In one case, the primary focus is on the individual's well-being. I mean, there is duties to warn and so on when people are dangerous, but the primary focus is on improving the person's ability to manage their illness and to achieve a quality of life. In the criminal justice system, the primary focus really is on the protection of society. And so if you don't get people from the two fields together at the same table, working together in the context of assertive community treatment teams, it becomes difficult to use that outreach productively and to prevent reoffending. There are forensic type ACT teams out there doing work. People are still trying to figure out how to make it work. One person I know very well, Steve Lamberti, who has been doing this kind of work, he developed Project Link in Rochester, I think over 10 years ago, has finally just received a treatment development grant to develop guidelines for the use of ACT teams in managing people with criminal justice involvement and with a particular focus on the use of legal coercion. There's no guidelines for how that should be used. So I think it's a very important area. Unfortunately, with a combination of enthusiasm for deinstitutionalization, but a lack of uptake on increasing rehabilitation services in the community, what's happened is that the jails and the prisons have picked up the slack. I believe the statistics argue that there are actually people are providing more services to people with severe mental illness in the prison and jail system than in the community mental health system. And an alarming number of people have their first contact in the jail system. So it's an incredibly important thing to address, I think. Just a little bit more, almost over here, but talk a little bit about illness self-management or illness management and enhancement. Now, illness self-management can be defined as the ability to manage one's psychiatric illness in collaboration with other people. And by manage one's psychiatric illness, when we've looked at different strategies for teaching people how to do that, what we've tended to focus on has been the management of the symptoms of the illness, kind of the psychopathology and the relapses of the illness. So when we're talking about illness management, in terms of illness management proper, we're talking about decreasing relapses and rehospitalizations, either coping with persistent symptoms, reducing distress, or reducing interference caused by those symptoms. That doesn't mean that the only focus of illness self-management programs is on decreasing symptoms and relapses. And in fact, we know, just as we know in terms of work in the substance abuse field and work with people with co-occurring disorders, the best way to motivate somebody to work on an addiction problem is by helping them figure out what they want in their lives and then helping develop discrepancy and motivation for changing destructive self-behaviors or poor substance use decisions and the like in order to achieve those goals. And so in the same way, with illness self-management approaches, there's often a combination of helping people articulate goals, helping them work towards achieving those goals, and then harnessing motivation to learn how to manage one's illness more effectively in the service of achieving personal goals. There's a variety of different illness self-management programs out there. There's one that was developed for this series for SAMHSA called Illness Management and Recovery, and it was a program that was built upon research examining different approaches to illness self-management. And the effective approaches were found to be basic education about the psychiatric illness, developing strategies to both help people make informed decisions about taking medication, and then if they make that decision, taking it, relapse prevention, coping with symptoms, and enhancing social support. There are other approaches as well, but the standardized model that was developed for the SAMHSA program called Illness Management and Recovery, now in fact, I used to call it a practice based on the evidence because the practice was formed based on those specific strategies that had an evidence base behind it. But now there's 2 randomized controlled trials and several more underway. They evaluate the effects of the overall illness management and recovery program. So another way of enhancing ACT services, which has certainly been done in a variety of different places that I know, in a number of states, like in specific places in Indiana and New Jersey, is to develop expertise in the teaching of illness self-management among members of the ACT team to the consumers. so that many of the functions that ACT team members sometimes do to help people manage their illness, that consumers themselves are taught how to do those things. And then, last of all, social skills training, enhancement of social skills training. I'm not going to go into this in a lot of detail, partly because I know in the early afternoon I'm going to be talking more about social skills training. We're going to have a discussion among Eric and Tom and myself, and inviting people from the audience to talk about social skills training. But in the same way that illness self-management, family psychoeducation, integrated treatment for dual disorders can be integrated into ACT teams by developing that expertise in those psychosocial rehabilitation areas, there's every reason to believe, and there are some experiences of incorporating expertise in doing social skills training. There's a number of reasons for thinking that ACT teams may be, in particular, well suited for providing those services. And a couple of those reasons are that we know that the clients served by ACT teams, by definition, I mean, by virtue partly of their frequent hospitalizations, tend to be some of the most impaired people with severe mental illness, with schizophrenia, but other severe mental illnesses as well. And those impairments include psychosocial impairment in terms of interpersonal relationships, leisure time, and self-care. And as we get into it later in the afternoon, the most powerful technology we have at this point for actually improving both social functioning and independent or self-care is social skills training. So the people who are receiving services on ACT teams actually probably need social skills training more than anybody needs it. So that's one practical reason why it makes sense to import and develop expertise in doing skills training on ACT teams. A second reason is that when, and again I'll talk a little bit later in the afternoon, but one of the things that we know about social skills training is that when people have cognitive impairments, they don't do as well at transferring or generalizing skills that are taught in a skills training session to the natural environment. Now there's several different approaches to addressing that. One approach has been doing cognitive remediation to try to increase response to social skills training. But the most standard approach to doing this, or approaches to doing this, which have been studied, have been to essentially engage in environmental engineering, where people both go into the natural settings and they practice the skills. We call this in vivo skills training, where people practice the skill in an actual situation. And then the second is engaging what some people, such as I think Bob Lieberman and Chuck Wallace at UCLA, call indigenous environmental supports. And now an indigenous support is a person who has regular contact with the client, but is not a member of the ACT team. Let's say you had somebody living in a board and care. Well, the indigenous supports in a board and care might be the board and care staff members. Let's say you have somebody living at home. The indigenous supports there might be a parent, sibling, or somebody like that, a family member. Let's say the person lives in a supported housing environment but has contact with family members or has a friend. The indigenous supports may be one of those people. So in social skills training, what you do, the way you program that generalization is you engage the indigenous support and you meet with them on a regular basis. And now I'll go into more detail, but you basically help them understand the nature of the skills that the person's trying to use, and you arrange for them to help the person practice it in the natural environment. Again, this is ideally set for ACT, which is a service in part defined by the fact that it's delivered in the natural environment as opposed to at the clinic. So consumers need need the skills training more. They're less likely to get it. They also need the environmental engineering in order to really learn the skills. And so these are all things that ACT teams have the capability of providing, but have not provided on a routine basis. Hence, the vast majority of the controlled research looking at the effects of ACT has not found effects on social functioning. And primary reason it hasn't found effects on social functioning is that skills training hasn't been integrated into ACT teams on a routine basis. But there's every reason to think that it is possible, and that's why I find this the entire focus of this conference very exciting and forward-thinking. So to wrap it all up, served community treatment is a very well-established approach to organizing psychiatric services. It's been shown to have significant effects in reducing hospitalization, on stabilizing housing in the community and reducing homelessness, in improving quality of life. There are also modest effects on symptom severity.